Good afternoon, everyone. We're going to get started. This is the session on the safety of Dolutegravir in pregnancy, late-breaking findings, interpretations, and implications. And we're quite delighted to have everybody here today, including our esteemed speakers. I'm Elaine Abrams from ICAP at Columbia University, my co-chair.
Good evening, everyone. Good afternoon, rather. My name is Wame Musime from the International Treatment Preparedness Coalition, ITPC. A warm welcome.
So we're going to get started immediately and begin with Dr. Lynn Moffinson, who's going to provide an overview on HIV treatment and pregnancy, the focus on safety.
Good afternoon, everybody. So as we all know, HIV is associated with significant morbidity and mortality for both the pregnant woman and her fetus and infant, and treatment is required for both maternal health and to prevent mother-to-child transmission. However, we only have limited data on antiretroviral drugs in pregnancy and lactation, and of the current 31 approved antiretroviral drugs, the mean lag between approval and any data, that means abstract data, on pregnancy is 5 years. And since 2010, of the 7 drugs that have been approved, we have no data on 3 of them. So they're big unknowns, particularly for newer drugs, pharmacokinetics and safety in pregnancy and breastfeeding, and fetal and infant safety. And these unanticipated findings with preconception dolutegravir demonstrate the critical importance of pharmacovigilance whenever you're introducing new drugs into a large adult population. So what I'm going to briefly do is talk a little bit about preclinical studies, whether there are differences in pregnancy outcomes between regimens, why timing of exposure is important, do birth outcomes vary by timing of antiretroviral start, are there differences between dolutegravir and efavirenz started during pregnancy, and end up talking a little bit about birth defects. So preclinical studies. So what's the predictive value of animal studies? The molecular basis of birth defects with drug exposure is known for only a very few drugs, and most human teratogens were first identified by clinical and epidemiologic studies, such as thalidomide, DES, valproate. And animals can be differentially sensitive to drugs. For example, thalidomide was actually negative in mice and rat embryo-fetal studies and only found to be positive for limb malformations in rabbit studies, and this is why the FDA now requires studies in at least 2 animal species. So to date, drugs known to be teratogenic in humans have shown teratogenic activity in mouse, rat, or rabbit studies, but often retrospectively. And while negative tests are reassuring, there's no absolute assurance that negative results obtained by testing drugs in these species can definitively predict that an agent will lack teratogenic effects in humans. And conversely, it can't be said that agents that are teratogenic in animals will necessarily be teratogenic in humans. For example, efavirenz causes CNS defects in monkeys, but not in humans. So do pregnancy outcomes vary by treatment regimen? So these are data from Botswana. In blue, you see any adverse outcome, preterms, SGA, stillbirth, neonatal death. And in green is any severe outcome, including very preterm and very SGA, by a number of different regimens, including efavirenz, nevirapine with 2 different backbones, and lopinavir. And you can see, compared to efavirenz treatment, there's an increased risk of adverse outcomes with all of these other regimens, ranging from a 1.2 to 1.9-fold increase. However, regardless of antiretroviral regimen, pregnancy outcomes were worse in HIV-positive women on treatment than HIV-uninfected women. And in that little box there, you see uninfected women. And compared to uninfected women, there was an increased incidence of adverse outcomes. Any adverse outcomes, 1.4, severe adverse outcomes, 1.5, regardless of antiretroviral regimen, and this includes efavirenz. So efavirenz-based treatment appears safer than nevirapine or Kaletra, but antiretrovirals, regardless of regimen, do not make pregnancy outcomes among HIV-positive women the same as in uninfected women. So why is timing of antiretroviral exposure important? And so this slide shows the timing of in utero exposure. You see fetal development, and on the bottom there you see different birth defect risks. So the first 2.5 weeks post-fertilization is the pre-organogenic period and is generally not sensitive to teratogens. Weeks 3 to 8 post-fertilization is the period of major organ development and is the most sensitive period for teratogens. For example, neural tube closes by day 28, so problems there will cause myelomeningocele. Oral structures form by day 36. With problems there, you get cleft palate. And because we're going to be talking about neural tube defects, I want to talk a little bit about the embryology. The neural tube closure normally occurs by 28 days, and it starts with a neural plate. The fusion of the neural tube can have several different origins of fusion, and it proceeds in both cephalad and caudal directions, forming anterior and posterior neuropores, with the head neuropore closing first and the caudal later. And this results in different phenotypes of neural tube defects, depending on the location and level of the defect. For example, if the cranial neuropore doesn't close, you get anencephaly. If the caudal neuropore doesn't close, you can get myelomeningocele. The development of the neural tube is a multi-step process that's strictly controlled by genes, but modulated by a host of environmental factors, including drugs. The exact etiology is poorly understood, but it's agreed that most cases are multifactorial, having some genetic sensitivity interacting with environmental risk factors such as low folate, no folate supplementation, or drugs. And the occurrence of defects in abortuses and stillbirths is many-fold higher than in live births. And it's a spectrum of maldevelopment that affects the neural tube as well as the axial skeleton, and depending on the onset during development, can affect different regions of the neural tube and non-neural tube organs. And there are two types, open and closed. Open arises during the process of primary neurulation. It's a primary failure of closure, and you get unclosed neural tissue, brain or spinal cord, exposed, and the most frequent ones are anencephaly and open spina bifida. And a closed defect is a neural tube defect that's covered by skin, and for examples here are encephaloceles and skin-covered lesions. So after 8 weeks post-fertilization, we enter the fetal development period, and problems here are like alcohol after 24 weeks gestation can cause fetal alcohol syndrome, smoking after 20 weeks, intrauterine growth retardation. So the message here is that the greatest risk for serious defects is not in women starting during pregnancy, but those who conceive while receiving the drug. But if you look at studies about drugs in pregnancy, most studies do not distinguish between the first trimester and preconception exposure. So do birth outcomes differ, other than birth defects, differ if starting before or during pregnancy? So in 2016, there was a meta-analysis of 10 studies with preconception treatment in over 9,000 women, starting during pregnancy in over 7,000 women, and preconception treatment was associated with an increased risk of preterm delivery, with the highest associations being in low and middle income countries. And since 2016, there have been 7 new publications that address this. 6 of the 7 also show this same association of preconception treatment with preterm delivery. So preterm delivery may be increased with preconception treatment compared to first starting during pregnancy. So let's talk about Dolutegravir versus efavirenz. These are data that Rebecca published right before this. When started during pregnancy, if you look, efavirenz here is in orange, Dolutegravir is in green, and you can see that these lines basically overlap. There's no difference in pregnancy outcome, any of them, preterm, SGA, etc. And there was no difference in major birth defects with first trimester exposure. There was 1 defect in the efavirenz group and none in the Dolutegravir group starting during first trimester, no neural tube defects. However, in purple, you see the outcomes in HIV-uninfected women, and HIV-uninfected women still have better outcomes than HIV-positive women on efavirenz or Dolutegravir treatment. So when started during pregnancy, the two regimens appear equivalent in terms of pregnancy outcomes, but again, the adverse outcomes are still higher than in HIV uninfected women. So ending up talking a bit about birth defects. So what's the expected incidence of neural tube defects? The estimated prevalence globally is 0.19%, ranging from 0.15 to 0.23%. And about 50% of cases are elective terminations and stillbirths, so if you evaluate only live births, you'll have an underestimation. This is a nice paper from African region, analyzed data from 11 studies from 8 African countries. The median prevalence of neural tube defects was 0.12, ranging from 0.06 to 0.23. And this was verified by a presentation done at this year's retrovirus meeting in Uganda, birth surveillance, over 43,000 births, 4,600 HIV-positive women, almost all on efavirenz, and the prevalence of neural tube defect was 0.09 in uninfected, 0.04 in HIV-positive women. Now, the ability to rule out an increase in birth defect is related to the incidence of the defect and the number of observed preconception and first trimester exposures. So, for example, if you want to rule out an increase in birth defects, overall birth defects with an incidence of 3%, you can do that with 200 exposures. But to rule out a threefold increase in a relatively rare event like neural tube defects, you need about 2,000 exposures. So the Antiretroviral Pregnancy Registry, which began in 1990 for AZT, is currently international, includes 128 drugs now, 49 brand, 79 generic. Providers prospectively report women on treatment during pregnancy to the registry prior to delivery outcome, and it's designed to provide an early warning signal. However, the registry is only as good as reporting to it is, and all of you take a picture of this number because you should all be reporting to the pregnancy registry. So these are the latest data from the pregnancy registry. The comparison groups are Atlanta Congenital Defects Program, overall defect 2.7%, Texas Birth Defect Registry, 4.2%. Now, for drugs to be included for comparison with population rates, a drug must meet a threshold of having 200 or more first trimester exposures. And you can see in the red square, first trimester antiretrovirals have a prevalence of birth defects overall that is similar to the overall population. But other than rilpivirine, Dolutegravir, and coxistat, there are insufficient data on the newer drugs, bictegravir, carbotegravir, Dolutegravir, elvitegravir, etravirine, tenofovir, alafenamide, to be able to rule out a twofold increase in overall birth defects, let alone rare events like neural tube defects. So drug therapy in pregnancy is a balancing act between the benefit of maternal treatment, the risk of fetal adverse effects. Unfortunately, there are often only limited data to be able to make recommendations. So with Dolutegravir, we have the benefits of rapid viral decline, better tolerated, less expensive for the mother, but we now have a potential signal for neural tube defects with preconception exposure. And many times I feel like we are in a maternal baby boxing match, and people are putting one against the other. And I would just see, as you will hear, there will be more data available to confirm or refute this signal in the next year. And in the meantime, we need to figure out how to maximize outcomes for both the mother and the child, not one or the other, not pitting them against each other. And that's it. Thank you.
Thank you. Just to inform the audience, we are not taking questions after the presentations, but have time set aside at the end of the session for questions and answers and some discussion. I'd like to next introduce Rebecca Zash, who's going to update us on the surveillance of neural tube defects following ARV exposure from conception and SISHAMO study.
Hi, and thanks to the organizers for this really important event. I'm going to talk about our surveillance for neural tube defects following antiretroviral exposure from conception in Botswana on behalf of the whole SAPAMO team. The SAPAMO study started in August of 2014. It's a birth outcome surveillance study funded by NICHD. And our primary aims were to evaluate adverse birth outcomes by HIV status and ART regimen, and secondly, to determine if there was an increased risk of neural tube defects among infants exposed to efavirenz from conception. Because in 2014, efavirenz was really the most widely available ART, and there was still some concern from early animal studies that it could cause neural tube defects. Botswana is actually a pretty ideal setting to do this kind of research. First of all, we have the ability to capture outcomes very well. The antenatal record is available for more than 99% of the women who deliver, and more than 95% of women in Botswana deliver in a healthcare facility, which is quite unlike some of the surrounding countries. Early termination is extremely rare. Botswana is also a place where there's a large number of exposures, a very high HIV prevalence in pregnancy of about 25%, and a high uptake of ART in pregnancy of more than 90%. Botswana is also unique because there's multiple antiretroviral regimens available at the same time, and more than half of women start their regimen before conception. So our methods, SAPAMO takes place at 8 of the largest maternity wards in Botswana, and it covers about 45% of the total births in the country. And at these 8 sites, our research assistants abstract data from the obstetric card for all in-hospital deliveries. This includes HIV positive and negative women, and live births and stillbirths. Specifically for congenital abnormalities, we trained hospital-based midwives on infant surface exam and congenital abnormalities using materials developed by WHO. And when an abnormality is noted, the midwife contacts one of our SAPAMO research assistants who consents the mother for a photograph of the abnormality. And these photos are reviewed by an experienced medical geneticist in Boston who's blinded to all of the exposure information. Our original analysis plan was for a 4-year analysis in August of this year to compare the prevalence of neural tube defects in liveborn and stillbirths combined among women on efavirenz at conception compared to our other exposure groups. But then in 2016, Botswana switched first-line ART from tenofovir FTC efavirenz to tenofovir FTC dolutegravir for all adults, including pregnant women, and they were the first high-burden country to do this. After this switch, we were able to capture women on dolutegravir started during pregnancy very quickly. And as Lynn said, we recently published an article to show that compared to those who started efavirenz during pregnancy, there was no increased risk of adverse birth outcomes among the 1,729 women who started their dolutegravir during pregnancy. And no major congenital abnormalities were identified in the relatively small number, 280, who started dolutegravir in the first trimester. But of course, it takes longer to accrue women who are starting their dolutegravir before conception because they have to start ART, then get pregnant, and then deliver to become part of our surveillance. But in April of this year, we were asked by WHO before the HIV Guidelines Committee meeting for outcomes among these women who started dolutegravir before pregnancy, preconception. And upon review of this data, we identified more neural tube defects than expected. And so we performed this unplanned analysis of NTDs, comparing births to women on dolutegravir prior to conception to other exposure groups. So this is our study population, and we are able to include data through the 1st of May. We had just over 89,000 births at our 8 surveillance sites, and we only excluded 309 who didn't have an evaluable surface exam. That left us with about 22,000 HIV positive mothers and 66,000 HIV negative mothers. Among the HIV positives, 11,726 started their ART prior to conception, including 426 on dolutegravir, 11,300 on non-dolutegravir ART, And among those, there were 5,787 specifically on efavirenz. There was also 2,812 women who started dolutegravir during pregnancy, and more than 5,000 who started a non-dolutegravir ART during pregnancy. So in our entire population of 88,755 births, we identified 86 neural tube defects, a prevalence of 0.1%, which was just about as we expected. Among these 86, there were 42 meningoceles and myelin meningoceles, which is also sometimes known as spina bifida. There were 30 anencephalies, 13 encephaloceles, and 1 iniencephaly, and 57% had photos. 22, or a quarter of all of our neural tube defects, occurred among stillbirths. And among live-born babies with the neural tube defects, 39% died within 28 days in the hospital, and 1 had an unknown vital status. So then this is our results by exposure group. Among the 426 with dolutegravir started prior to conception, there were 4 neural tube defects, which is a prevalence of 0.94%. Among the 11,300 who started a non-dolutegravir ART prior to conception, there were 14 neural tube defects, a prevalence of 0.12%. Among the 5,787 who started efavirenz before conception, there were 3 neural tube defects, a prevalence of 0.05%. Among the 2,812 who started dolutegravir during pregnancy, there were no neural tube defects. Among the 5,624 who started a non-dolutegravir ART during pregnancy, there were 3 neural tube defects, a prevalence of 0.05%. And among the 66,057 HIV uninfected women, there were 61 neural tube defects, a prevalence of 0.09%. And what you can see here in the graph is that the confidence intervals for the DTG conception group do not overlap with any of the other exposure groups. And in the last line of the table, I presented the absolute prevalence differences between the groups, which are about 0.8%, and that is all statistically significant. So the 4 defects that we identified among the women on dolutegravir at conception were 4 different neural tube defects, including an encephalocele, an anencephaly, a myelomeningocele, and an iniencephaly. None of the women were reported to be on folate supplementation prior to pregnancy, and Botswana is a country that does not fortify grains with folate. I have to say that this was similar to all of the other exposure groups we had, where there was almost no supplementation prior to pregnancy. And then we reviewed all the maternal data that we had available and found no other risk factors for neural tube defects present in these 4 women. We wanted to figure out if there could have been a recent increase in neural tube defects to help explain our results. So what you see here is the number of neural tube defects by month in the entirety of our study, and those little red bars are the dolutegravir at conception. And I think you can see visually that there's been no increase overall, and we did a formal sensitivity analysis that showed that when we restricted just to births that had happened since the rollout of dolutegravir, our results were the same. We also tried to see if there was any clustering by site that could help explain, and there is not. And we also looked at a common minor abnormality, which was postaxial polydactyly, which is a little tiny extra digit on the pinky side, which is very common, about 1% in our population, to see if there could have been differential ascertainment of infants by exposure group. But there was no difference there. So since the 1st of May, our study has been ongoing, and we found 2 more total neural tube defects in our entire population. The first was in an infant exposed to dolutegravir started during pregnancy, and the other was to an HIV-infected woman. The neural tube defect started during pregnancy. Dolutegravir during pregnancy was the first in that group, and so now there's 1 in 3,104, a prevalence of 0.03%. We also had 170 more exposures to dolutegravir at conception with no more neural tube defects. So there's 4 in 596 in this group, a prevalence of 0.67%, and the 95% confidence intervals still do not overlap with any other exposure group. And then I put the neural tube defects over time again in the slide just to show you visually that while we are happy that there hasn't been another one, there was 2 to 3 months between each of our prior neural tube defects, so I'm not sure how much we can take from this information. We've also formulated an updated analysis plan, and we're going to do our next formal analysis after the end of March 2019. And this date was chosen because it's about 40 weeks from the time that the warnings came out about dolutegravir. So it will include women who were already exposed to DTG at conception prior to the guidelines change. We're also in the process of expanding our sites from 8 to 18 to increase our coverage of births from 45% to 72% in the country. And in our final analysis next year, we'll include not just neural tube defects, but also other major malformations and other adverse birth outcomes. So with our expanded surveillance to 18 sites, we're estimating that by the end of March, we'll have covered gotten information on about 1,226 births with exposure to dolutegravir from conception. And you can see here, if there's 0 more events in this group, in the top line of that chart, the total prevalence will be 0.33%, and the lower confidence interval will be 0.13%, which does overlap with the upper confidence interval for all other ART at conception, efavirenz at conception, and HIV uninfected. If there's 1 more event in this group, you can see the total prevalence will be 0.41%, and the lower confidence interval of 0.18% will overlap with other ART at conception. So in conclusion, we've identified a concerning but definitely preliminary early signal for dolutegravir and neural tube defects that really requires further data to confirm or refute. This is based on only 4 cases. The absolute prevalence difference is small, and the 4 different defects among infants exposed to dolutegravir is unusual. And just in closing, I want to thank, first of all, a most amazing study team on the ground in Botswana, including Modiahi Deseko and Gloria Mayandi. I don't know where they are in this crowd, but they're doing an amazing job and helping us to get from 8 to 18 sites as quickly as possible. And I also want to thank all the women who allowed us to take photos of their infants and have been in our study. And I think that it's very important to listen to their voices as we think about how to use this data. Thank you.
Thank you, Rebecca. I'd like to now introduce Martha Okello from ICW East Africa, who will give us the community perspective.
Good afternoon. As you've been told, my name is Martha, and I work for the International Community of Women Living with HIV Eastern Africa. And I will talk about the community perspective to what has been happening around DTG. I would like to really thank the scientists for giving us quite a lot of information that has also been able to help us have quite deep discussions with the women across the continent. We've had discussions in different countries on what the women living with HIV would really want to see being done around DTG. And just last week, we had women from 18 countries converge in Rwanda, where we came up with a statement, which I'm sure you've seen by now, talking about what women would like to see happen around DTG. First and foremost, we definitely are concerned when we hear about NTDs being linked to any antiretroviral drug. And as you've heard, there doesn't seem to be any antiretroviral drug that does not have some risk of some sort. And women living with HIV definitely want to have babies who are safe, because it's a motivation for them to live another day. It's a motivation for them to, to see tomorrow, to see their children graduate and have a better life. So we get concerned when we hear this. But I think for the women, it was kind of by surprise. We were taken by surprise by the guidance from WHO. And then very shortly, different countries followed suit, giving guidance that was not really taking into account different scenarios. We all know that women living with HIV are not homogeneous. I could actually be in my reproductive health age, but I don't feel like having a child at that moment. And probably I also want to have a drug that works for me. I want to have a drug that has less effects. Some women are done having children. They've had the number that they have. Some women, for example, in Uganda, when we had consultations, we had women from special groups like K-pops, and some of them said, why can't I have, if I'm a transgender woman, why can't I have DTG? I mean, I'm probably not planning to have a child, or I won't be having a child, so why can't I have DTG? And the concern the women had was, I think we needed to be consulted before this came out, because we have issues that DTG could have probably helped us solve. And I'll go through some of the things that came out very critically. The first one was the issue of treatment as prevention. The group that most of the African countries decided to exclude from DTG is the group that reports a lot of cases when it comes to lack of adherence. It's the group that definitely has issues of less adherence, as I've said. And we are saying, this is the group that needs DTG. Is there something we can do for them to have DTG? We've also had that, for example, in Uganda, that actually infections start at about the age of 18 to 25. And we know that DTG is good in virus suppression. So we are denying these women the opportunity to virus suppress, because many of them in these consultations said, look, with efavirenz, of course there are some who said efavirenz works for them, but they said, look, with efavirenz, some of us have had to throw the drugs for 8 months because we cannot work anymore, we cannot look after our families, we are struggling with it. So why won't we get a drug that works for us if we give us information on how best to use this drug? So that is something that this guidance denied these women. The other thing is that we definitely didn't see the opportunity to exercise choice when it comes to what you should have. This guidance prescribed for the women what they should have or what they should take or not. And for example, in some countries, they said you have to be 15, all those who are 15 to 49 of reproductive age will not be on DTG unless they are on a long-term family planning method, or probably they have undergone sterilization. What this means is that we are saying that, okay, for you to have DTG, you can as well get sterilized. And this is a group that also would like to have children. And we already have cases like in Kenya where women have been coerced into sterilization because of just having, say, milk for their babies. So now we might as well see a case where actually people will get sterilized because they want to access a good drug for them to be able to live a better life. So that is one of the concerns that the women had. So how are we translating this guidance in the different countries is quite important. Some countries, the language is being translated into something. Probably, I don't know whether that is what WHO meant, or probably the countries have decided to translate it differently. So, can the women have some choice? Can the women get information to be able to take critical decisions that matter to their lives? Can we at least hear them out so that they can be able to to exercise choice or to be able to get that information. The other thing really is DTG gives us a very good opportunity to work on our family planning services for countries like the one where I come from. We cannot say that because we currently have challenges in terms of our family planning process, services, we should not be bringing DTG. For the community, we look at this as a very great opportunity for ensuring that we integrate services, that we actually run one-stop centers for family planning and for art treatment, and that we can now see, we will be able to see more women access family planning. So for us not to think about DTG from that other positive aspect is definitely missing a point, is definitely missing a silver lining on all this conversation. So we would like to see the voice of the woman really taken into account in these discussions. We would like you to look at women not as don't give us a one dress fits it all situation here. Give people choices, give them information. We also know that when efavirenz came on board, people used to, because they had information that this could affect your baby, they used to go off efavirenz for 3 months, have the baby, then come back to the clinic. So that shows you that information is very powerful, and that if the women are given the information, supported to be able to, have this information and make decisions, they will definitely do the right thing even under DTG. So give the women information as much as possible, give the women choice, and the women will definitely do what is right even in circumstances of DTG. Thank you so much.
Thank you very much. I would now like to invite Meg Doherty from the WHO, who's going to be giving a presentation on data from other cohorts, regions, to guide decisions.
Thank you. And I just have to say it's a bit of a tough act to follow. And I from the WHO's perspective, we're in agreement, and we'll walk you through a bit of what we've been doing since the very first safety alert that came out. And for many of you who were with us yesterday at our WHO session, we shared with you the policy directions, which are the recommendations. And I think in the policy directions, I think we've made a good effort to incorporate choice, and we're committed to be working with communities in terms of the dissemination and implementation of the recommendations. And at this meeting itself, we've had at least 4 or 5 conversations, and we'll continue with women who are living with HIV around what women want, what choice means, and how we're going to start to work better on this integration of SRH. So with that being said, you are right. WHO did put out, after we learned about the safety signal, the concern and the risk of neural tube defects, having seen the data that Rebecca Zash shared today, we did put out a safety signal at the same time as other regulatory bodies, and this came from our drug safety alert from WHO, which is through our essential medicines program. And these kinds of characteristics of drug safety alerts are drug-centered, often more restrictive, considered in major clinical scenarios, and at the same time, FDA, EMA, and others also put out their statements along with a Dear Doctor letter for those who received Dolutegravir from ViiV and others. But that's slightly different, and that's why the challenge is WHO is not one homogeneous organization, that we also create guidelines. And this was simultaneously as we were looking through all the evidence and the data on clinical outcomes around guidelines. And yesterday and today, we're sharing with you the content of those guidelines, and these are how we can address the problems of a potential safety alert, and what policies can be put into programmatic action at countries to help with that decision making. So yesterday you saw we shared with you a new document which is updated for 4 questions, really about updating our first, second line treatment for adults all the way to infants and neonates. as well as recommendations around the use of PEP and recommendations around around implementing an optimal approach to early infant diagnosis testing. And what you'll see here is that we have said that very permissively that based on the evidence and the systematic reviews, that dolutegravir-based regimen may be recommended as the preferred first line for people living with HIV initiating ART. This is a conditional recommendation taking into the fact that the context of the data or the content of the data are different by different populations. So women and adolescent girls of childbearing potential. Now we've changed our language. Childbearing potential is a language that's used mostly with regulatory agencies. And this helps us because I believe it's not necessarily restricted to age, but it's about desire for pregnancy and when one is thinking about pregnancy. And this evidence was also taking into account the information that we've learned from the neural tube defect data from Botswana. But what we do know from our network meta-analysis that dolutegravir is better than efavirenz 600 in terms of viral suppression. Treatment discontinuation is lower, as well as CD4 recovery is better. And then looking through the data, that the guideline committee made that recommendation, but also wanted us to also include a note of caution for using dolutegravir in women and girls of childbearing potential. And with that, we said that dolutegravir could be safely used with consistent and reliable contraception. We've reviewed the data on hormonal interactions with dolutegravir, and we feel that almost all the hormonal contraceptions can be used safely, although more data are needed. We also did say that efavirenz-based regimens are still considered safe and effective first-line regimens and can be used among women who would like to have a child. We also are very much focused on a women-centered approach and making sure that our guidelines are based on autonomy and decision-making, and this is something that I think is going to be programmatically a bit challenging in countries as they start to ensure that there can be choice for women and that there can be enough commodities to be able to accommodate that choice. But all of our guidelines include community members on the guideline committee membership, and it's really based upon the women's autonomy and decision-making as a primary principle. So this is the slide that most people like to see. I'm going to now skip through a few slides that just gives you the basic guidelines, and these are going to be online very soon, or if they're not already online. But we say tenofovir, lamivudine, and dolutegravir is a preferred first line with efavirenz as an alternative first line. For women and adolescent girls of childbearing potential who want to become pregnant and have no effective contraception, we are still recommending a TLE 600, but I understand that this is going to have to be the challenging conversation that needs to happen at all consultations. We made a recommendation that it can be used during tuberculosis treatment with rifampin by double dosing the dolutegravir, which is based upon the study that came out of Kelly Dooley's group, as well as it can be used with HIV and hepatitis B co-infection. We also recommended that dolutegravir can be used in second-line regimens for both adults and children, and I also don't have a slide on it, but dolutegravir can be used in children up to the age of 6. We also have somewhat modified the way we do first, second, and third line. Because of this, we would say that if a person starts for dolutegravir as first line, then they would change to another regimen, including a PI, boosted PI, in second line. However, if they start an efavirenz-based regimen in first line, then they should be changing their nucleoside backbone. So we're looking for an optimized nucleoside backbone, or nucleotide backbone with the dolutegravir. And as well, we also see a role for dolutegravir potentially in third line with a combination of darunavir. When we look at our guidelines across the board, when you compare DHSS guidelines and BIVA guidelines that came out also after this safety alert, I believe we're in a line, and if not, a bit more permissive than some of the recommendations that are available. We also had an online and also community consultation talking about should women and adolescent girls who are starting ART for the first time take regimens that contain dolutegravir. Now, this was among people living with HIV before the neural tube defect was identified and shared with us. And as you can see, it was really 50-50 when we think about yes or no. We then went back and with a group that was meeting in person, we also shared this online survey. Now, if your health care provider said that you could take dolutegravir as well as taking contraception, would you take dolutegravir? And the primary answer that came out now was, or the majority, wanted to have their health care provider provide them with more information so that they could make an informed decision. So I agree with the commentary that the silver lining of all of this is that we need to strengthen and integrate sexual and reproductive health services, and that we need to break down some of those silos. And I think under the leadership of WHO's new DG, Director General, if you heard last night, we have universal health coverage. We're going to integrate our services. And I think this is a great opportunity to also get our donors interested in the commodities for contraception. Now I'm going to spend just a bit of time on the data and where we're going from there, because the data is very nascent, but there has been many groups since May the 18th. We have been meeting at least every two weeks or once a week on conference calls, and there's been several groups that have come together to look at what are the data that we need, where are we going to go with the data, how are we going to know we'll have enough information to confirm or refute. And the types of data you heard already from Lynn this morning was pharmacovigilance in the databases. And there are limitations there in that we don't have consistent denominator and we don't have very good numerators sometimes, that we have multiple numerators. So we need to improve our repositories. We have clinical trial data, and that's somewhat limited because there's somewhat limited enrollment of pregnant women in our clinical trials. So that says something about our clinical trials and how we can use that to help us with information about pregnant and women who have childbearing potential. We have basic science, and there's going to be an effort to try to understand could there be a mechanism? Can this be explained? Is this causal or not? And lastly, we have country policy and programmatic data. And I think this is the type of data that WHO follows very carefully. And we have both retrospective data and prospective data. And we believe that the greatest information we're going to get in terms of helping us to confirm or refute will come from the prospective data and active surveillance of what you heard in Botswana. So what we do know in terms of policies, that we have already 71 low and middle income countries that have already introduced dolutegravir into their guidelines or starting to roll out, with many more planned with a large trajectory. We know that we have 3 very forward-thinking countries that have been implementing for several, either a year or 2 years, and that includes Botswana, Brazil, and Kenya. And we believe most of the data around prospective data will come from these 3 countries, because they've already set up at different kinds, but toxicity and pharmacovigilance monitoring programs. And many of them have been focused on some of the other toxicities that people have asked us about, with very low levels of other toxicity. Others are looking at drug resistance and viral load. But we also know that we have few hundred from both Kenya and Brazil who will be able to follow up and find out if they too see any evidence of a neural tube defect. And you already heard from my colleague that they will be scaling up to reach practically 91% of all the pregnancies in Botswana between the Harvard Botswana program and the CDC that will be starting a study as well. What we also know is exactly what our previous speaker said, is that right after we put out the message, countries took that differentially, and they started to implement policy changes and guideline changes differentially. And I think this was a bit of a pause for all of us. It was really an unwanted, unexpected finding, and many countries also wanted to make sure that they put in policies in place to protect both women and children. And what we know that most of the countries that we have been in communication with, and we've already had 56 countries that we've been speaking with regularly, that they're taking time also to see what our guidelines say so that they can adapt and adopt. Some of the countries that had to move quickly did so because they had requirements for procurement that were urgent. And what we do know is that here, that we have a number of countries that have already started to put into their guidance specific language around choice and contraception so that women will have access to dolutegravir with contraception. The other thing that we're going to have to work on with countries now is we have several countries that during pregnancy are stopping dolutegravir. And we don't have a lot of information or guidance on what we should be doing there. And eventually we believe that there will be some challenges with stopping and starting drugs during pregnancy. And we'll be working with countries to try to inform them about what the WHO would recommend in that situation. So there's many challenges in country post-alert in terms of understanding what contraception means in terms of consistent and long-term and active. Injectables are not available. We believe less than 30% accessibility in many countries. And we also know that we've heard that adolescent girls are probably a group that we need to be thinking about specifically because of the potentiality for resistance and the lack of access to contraception. Yes, this is my almost last slide, but we do know that there is a lovely perspective, in the New England Journal today. And I think what they point out is the lack of data are a problem. And so I will wish that you would come and hear more about the data opportunities that are available. And just to note that over the next 12 months, we'll be convening with people to be able to understand what those data are, all of our partners and the safety partners. And we're committed to collecting and reviewing the data as it becomes available. So join us to hear what the countries are doing and how one could contribute to some of the databases that are available. So thank you.
Thank you very much, Meg. I would now like to invite the next speaker, Caitlin Dugdale, to present on risks and benefits of DTG-based ART in women living with HIV of childbearing age in South Africa.
Great. Okay. Well, on behalf of all of my co-authors, I'd like to thank the organizers for the invitation to present at this session. And I have no disclosures. As we were just hearing, global rollout of first-line dolutegravir-based ART was planned for 2018 due to its improved efficacy, tolerability, and high barrier to resistance compared to efavirenz-based ART. But in May of 2018, data from SAPAMO suggested an association between the use of dolutegravir at conception and neural tube defects. And again, as we just heard, on May 18th, the WHO issued a statement that ART for women of childbearing age should be based on drugs for which adequate safety data are available, namely efavirenz. Our objective was to conduct a model-based analysis of the range of possible clinical outcomes associated with dolutegravir-based versus efavirenz-based ART for women of childbearing age and their children over a 5-year period in South Africa. So why use a model? It's currently unclear whether the early signal of an increased risk of neural tube defects with dolutegravir will be borne out with additional data. While awaiting those data, models can provide insights about the potential public health implications of different ART regimens for women of childbearing age and their children. Importantly, in this modeling analysis, we provide quantitative outcomes for decision makers. We do not attempt to determine how to balance these trade-offs, as the value of each outcome is highly individualized and context-specific. In this analysis, we modeled 2 strategies for women. In both, we used a public health approach in which one ART regimen is recommended as first line for all women of childbearing age in South Africa. We compared a dolutegravir strategy of initiation of or switch to dolutegravir-based ART to an efavirenz strategy with initiation of or continuation of efavirenz-based ART. We used the well-established cost-effectiveness of preventing AIDS complications, or CPAC International and CPAC Pediatrics, computer simulation models of HIV infection. We parameterized the models with data from South Africa, and we projected outcomes over 5 years, including sexual transmissions to partners, deaths among women, neural tube defects, pediatric HIV infections, and deaths among children. We modeled 2 cohorts over 5 years. First, we modeled a cohort of women, 15 to 49 years old, living with HIV in South Africa. We considered both the 1.7 million women already on ART and the 1.8 million women expected to start ART over the next 5 years, totaling 3.5 million women based on UNAIDS estimates. We also modeled a pediatric cohort of the HIV-exposed children born to these women, projecting 1.1 million children born over the next 5 years. In terms of key model inputs, the neural tube defect risk with dolutegravir was 0.9% from Supamo and was lower at 0.05% with efavirenz. We assumed 100% pediatric mortality with neural tube defects. Fertility rates ranged from 2 to 139 per 1,000 women. The risk of sexual transmission ranged from 0.16 to 9.03 per 100 person years by HIV RNA. And we modeled peri- and postnatal transmission risks based on maternal ART use, CD4 count, and virologic suppression status. Model inputs for ART efficacy were derived from the single trial, the largest published head-to-head randomized controlled trial of dolutegravir and efavirenz. Using single trial data, we derived a 48-week suppressive efficacy of dolutegravir of 94%, which was lower with efavirenz at 86%. The CD4 count increase at 48 weeks on suppressive ART was 267 cells with dolutegravir and lower at 208 cells with efavirenz. To assess the impact of key parameters on deaths among women and children, we conducted multi-way sensitivity analyses on the risk of dolutegravir-associated neural tube defects, efavirenz suppressive efficacy, and the fertility rate. We also conducted sensitivity analyses on several aspects of our ART efficacy parameterization from the single trial. In single, adverse events were considered as regimen failure. We simulated regimen failure as causing viral rebound prior to a switch to second-line ART. We also challenged the assumption of viral rebound following ART discontinuation with adverse events, changed the definition of virologic failure, and varied the 48-week suppressive efficacy of dolutegravir and efavirenz, all to reflect non-trial settings. And now we turn to the results. 5-year outcomes for women and children in South Africa are shown. Modeled outcomes that favor the dolutegravir strategy are in red, and those that favor the efavirenz strategy are in blue. Dolutegravir demonstrated benefit over efavirenz for 4 key outcomes. The number of deaths among women was 263,200 with dolutegravir, and higher with efavirenz at 291,600. Dolutegravir was therefore projected to avert 28,400 deaths among women over 5 years. Relative to efavirenz, dolutegravir was projected to avert 52,800 sexual transmissions and 5,000 pediatric HIV infections. Dolutegravir also averted 1,600 non-neural tube defect-related pediatric deaths, and this was largely due to prevention of pediatric HIV transmission or infection. Efavirenz demonstrated benefit with 3 key outcomes. Efavirenz was projected to avert 10,000 neural tube defects relative to dolutegravir based on the point estimate from Supamo. Efavirenz also reduced cumulative pediatric deaths, including both neural tube defect-related and non-neural tube defect-related deaths, by a total of 8,400. With efavirenz, 5,400 more children were projected to be alive and HIV-free at 5 years. At current best estimates, the use of dolutegravir among women of childbearing age would avert over 3-fold more deaths among women than the use of efavirenz would avert deaths among children. We performed a multi-way sensitivity analysis to evaluate whether our results were robust with plausible variation in 3 key parameters. The dolutegravir-associated neural tube defect risk is the key uncertainty in this analysis. Therefore, we varied this risk widely from 0.2% on the left all of the way up to 3% on the right. Along the vertical axis, we varied the 48-week suppressive efficacy of efavirenz from 80% to 90%. In this first figure, we used the base case fertility rates from South Africa. Areas shaded in yellow to red tones indicate where deaths averted among women with HIV exceeded pediatric deaths added in the dolutegravir strategy. Areas shaded in blue tones indicate where pediatric deaths added exceeded deaths averted among women with dolutegravir relative to efavirenz. The base case is indicated by the black X on the left. At the base case efavirenz suppressive efficacy of 86%, there were more deaths averted among women than pediatric deaths added, unless dolutegravir-associated neural tube defect risk was greater than 2.6%, as demonstrated by the green arrow on the right. Even at the highest threshold of efavirenz efficacy examined, there were more deaths averted among women than pediatric deaths added, unless dolutegravir-associated neural tube defect risk was greater than 2.4%. This is shown in the light blue areas in the top right of the figure. This tipping point of greater than 2.4% is well above the point estimate of neural tube defects with dolutegravir from Supamo, and just above the prior upper bound of the current 95% confidence limit reported from that study earlier this session. We also performed a multi-way sensitivity analysis to evaluate whether our results are generalizable to settings with 2 times higher fertility rates than South Africa, as might be found in Tanzania or Uganda, for example. At higher fertility rates, the impact of neural tube defects increased. Here, pediatric deaths added exceeded deaths averted among women in the dolutegravir strategy at neural tube defect risks greater than 1.2%, as shown in the blue tones on the right. Results were robust in all of the sensitivity analyses regarding ART efficacy parameterization from single, including analyses of viral rebound after adverse events, different thresholds to define virologic failure, and plausible variation in suppressive efficacy of both dolutegravir and efavirenz. Our analysis has a number of limitations. First, most importantly, we did not assess an individualized approach to ART recommendations, with dolutegravir for some women and efavirenz for others. Facilitating access to contraception, or women's individualized, informed choice of ART, could lead to different results for both women and their children. Secondly, our ART efficacy inputs were informed by the single trial, which was performed in resource-rich settings. However, we varied efavirenz suppressive efficacy widely to reflect settings with more than 10% pretreatment drug resistance, as has been reported in sub-Saharan Africa. Lastly, and critically, it is unclear whether the early signal of increased neural tube defects with dolutegravir will be borne out over time. Evaluation of this uncertainty was really at the crux of our sensitivity analyses. So in conclusion, dolutegravir-based ART would avert more than 25,000 deaths among women of childbearing age and 5,000 pediatric infections compared to efavirenz-based ART over a 5-year period in South Africa. These benefits may come at the expense of pediatric survival if the increased risk of neural tube defects with dolutegravir from Supamo persists with additional data. However, there would be approximately 3-fold more deaths averted among women than pediatric deaths added with the use of dolutegravir for all women of childbearing age with HIV in South Africa. These risks and benefits should be weighed carefully as policies for ART use are implemented globally. Thank you.
Thank you very much. I would now like to call our last speaker, Maggie Little, weighing up the risks and benefits. Thank you.
How do I pull up the next? Got it? Great. Good afternoon. I'm here as the last speaker after you've all been very patient, and I know on the edge of your seats listening to these amazing results. I'm here to speak as somebody who is not a scientist, but as somebody who is a bioethicist, that is, does ethical frameworks, and the area that I've been working on is, for many years, ethical frameworks around research, around women's reproductive lives. So in particular, I'm here representing a project called Phases. Let me start by telling you just a bit more about that project. So Phases is a multi-year NIH-funded study led by U.S. investigators, I'm one of the PIs, with partners in Botswana, Malawi, and South Africa. So for the last 3 years, we've been talking to women there. We've had consultations with over 140 HIV researchers, policymakers across the globe, talking about what women living with HIV or at risk of HIV deserve in the way of medications and preventions, and deserve in the way of evidence. The aim of the project is, in partnership with these partners, developing frameworks to advance research at the intersection of women's reproduction and HIV, and advocating for earlier, better, and more evidence on implications of medication use in pregnancy. Because right now, for many medications, including in HIV, we have a very, very poor evidence base for safety and efficacy in dosing, and Lynn spoke eloquently to that. This leaves pregnant women or women at the periconception phase, right, as second-class medical citizens. Some people have said there is no population that has a poorer evidence base for the medical decisions they must make, often in life-challenging situations. So with that in mind, our project has been looking at, women deserve safe and effective medication over the course of their lifespan, including during pregnancy, and deserve an evidence base adequate to that fact. So our project has been talking with people about Dolutegravir since the results came out. Progress and challenges, both. So first, let's remember, this represents critical progress. So here, in contrast to what so often happens, where there's not an evidence base, we're doing the research to find out. Okay? The research is of high quality, beautifully designed. Further, the world's response has been strong. It's been swift, thoughtful, in consultation with women in affected communities. We'll have some disagreements about ultimately what the policy should be. That's part of what we're talking about here today. But in general, the world stepped up to the plate when this finding came through. Finally, the research will continue. As we've heard, the world has responded and said, let's increase the study site so that we can quickly gather enough evidence to give confirmation about what the real risks here are. Okay, so this is good news. It doesn't feel like good news. Sometimes it's be careful what you wish for. Okay, 2 challenges I want to speak to briefly. The one is, in a sense, the timing of the research. So just putting this in a narrative context, Dolutegravir coming out as a beacon of hope, right, for women living with HIV around the globe, for all the reasons that the other speakers talked about, with its many multiple advantages, okay? The world ready to start rolling this out and making lives better for women, their children, and others as well. And after it's begun to be rolled out in some countries, then we get a, wait, hold on, hit the brakes, okay, and try not to panic when you do, okay? And think of everybody here. The researchers who did this gorgeous study, oh my gosh, what did we just find? And did we upset the apple cart? The women who have been anticipating taking DTG, right? The global policy communities of the WHO, right? So the world wanted DTG to work, okay, and then finds an unexpected and deeply distressing finding, okay? The timing can feel like, couldn't we have known that earlier? Okay. And I'm going to come back to that. The second one is, this kind of finding, still preliminary, right, but asks us to confront what is for many people an uncomfortable scenario, confronting potential trade-offs between women's health and the health of the children they bear. And this is something in general we tend to have a cultural anxiety around and not want to face and think that we can't face. Okay. So Dolutegravir is asking us to look at that. I want to take each in turn. First, on the ethics of timing, as it were. So as I mentioned, one of the things our project is deeply committed to is moving up the timing for when we get evidence to guide our decisions about what medications to use. So if a medication is likely to be used by women who may become pregnant, evidence about its use should be intentionally collected as early as possible. That seems like a really good ethical principle. Okay. That said, what this study picked up was a relatively rare occurrence. And rare safety events aren't going to be picked up, even in beautifully designed interventional clinical research trials. Not just for pregnant women, but in any research context, right? We're not done gathering evidence just when we do the rollout, okay? So some of what Dolutegravir's story is reminding us of is that even as we release a new intervention into the community, we have to have very strong surveillance, and we have to remember to stay agile, right? We have a strong hypothesis about what's the right thing to do, but we are still awaiting confirmation. It underscores the importance of community engagement, right? That we have to be in conversations with our communities about what rollout means and where it's at. We still might get something unexpected and distressing, didn't mean we did anything wrong, okay? It also underscores, and this is lesson number 1, I'm only going to have 2, and this is the first one, that studies like this beautiful post-rollout surveillance study, should not be left to chance when we roll out new medications, okay? This study was almost an accident, right? Somebody decided to do this beautiful job of checking efavirenz, got NIH funding, right? It wasn't a plan. Somebody had to have the passion to go, and can you imagine the work this was getting it through the IRB, right? And then decided after Botswana rolled out Dolutegravir, hey, let's just go ahead and add checking out for DTG. Okay, so first of all, heroes. I'm looking at some of the heroes, and heroes, okay? And why are we leaving this to chance? Why isn't it the case that what pregnant women and their children deserve is for every new intervention, preventive or treatment, that is rolled out for HIV and its comorbidities, we should proactively have an intentional plan for how we're going to check for safety signals that can't be found in clinical trials. There's manifesto statement number 1. Okay. Next, let's turn to that second difficult issue, as it were, the ethics of trade-off. And I want to start with the possibility of trade-offs in mortality, right, which Caitlin beautifully just spoke to. Okay. So we really need to acknowledge that there may well be trade-offs between mortality, and it might go in either direction, right? Depends on all sorts of assumptions, right? It may be that you can end up saving more women's lives, but at the expense of children's lives, or vice versa, that right, we don't have the evidence and we haven't tested all of the assumptions yet. And as Lynn pointed out, this starts to look like the World Health Community is talking about a boxing match, pitting the woman against her children. Okay? Deeply wrong way to think about it, right, as Lynn herself was intimating and has said to me. So how do we think about it? First of all, a reminder, and as Caitlin was herself saying, the numbers alone, even if we got confirmation on the differential mortality, okay, they'll never tell us the answer. It's not like arithmetic is our moral guide here, right? It's not like if magically the numbers of maternal deaths and pediatric deaths were equal that we could say it's all okay, right? We have to have a discussion about whose lives, under which circumstances, and how are we otherwise burdening people's lives, including women's lives who are doing the lovely thing of bearing these children. Okay. Complexity. When we're talking about women and the children that some of them will bear. First of all, if a woman is pregnant, she's not thinking of it as a boxing match between her baby and her. It's not us versus them. To her, she's deeply committed, right? And this is what Martha was so beautifully saying. Of course, the women care and are concerned, right? And for a million reasons, intrinsically loving and caring for the baby that you're going to have. And also, a catastrophe for the baby is usually a catastrophe for the woman's life. Okay. Yet, women willing, or in fact, gestating another life and building a person, right? Growing a baby, shouldn't be expected to infinitely self-sacrifice on behalf of their children. So even if it turned out that the numbers were unlike in Caitlin's beautiful model, what if it were the other way? It still shouldn't mean that, therefore, we have to save the children's lives versus the mothers, because who is being asked to carry the burden and sacrifice? women should not be held to expectations of self-abnegation for the sake of their children in some infinite sense. And finally, please remember, right, that in these aggregate statistics, right, we're talking about women of childbearing potential. So when there's differential mortality, now let's go back to Caitlin's, lots of maternal deaths may be at stake to save those pediatric lives. Okay, and some of those maternal deaths are of women who never would have been pregnant, right? So it's on behalf of a child you might have that you're supposed to get substandard care for your own illness. That seems deeply worrisome. So here's when we begin to talk about the choice that so many of our panelists have beautifully already started to articulate. We need to remember, whatever the numbers say, we need to talk to the people who would be affected. There's a difference between a sacrifice a policy may impose on women, right, by deciding what's available to them, and a sacrifice a woman may not, but decide to make in the context of her own life, knowing the specificities. Okay. Let's set aside maternal mortality for a minute, okay? Because I don't want it to just be, again, the boxing match of 2 minutes, of whose life, right, whose death, as it were, do we somehow value more? Because remember what was so important about Dolutegravir and is for women, and it's, again, what Martha was speaking of so eloquently. The Dolutegravir, in addition to saving women's lives, also can make their life livable. Okay? Substantial benefits to quality of life in addition to reducing women's mortalities. Okay? Things like being able to have enough energy to take care of the children you already have, or go to school, or have your job. If you're susceptible to depression, you really might worry about efavirenz these days. Okay? Possible workarounds, like, well, let's just switch when they're on and off based on pregnancy. Those might work in some high-resource settings with some individual women, but probably not in large-scale public health rollouts. So there are really constraints on just trying to micro-target. So it's not just about women's deaths, but their lives. It's highly contextual. Martha spoke better than I could about the women's particular scenarios, as she put it, that might mean a woman would say, this is why I want DTG, even though, of course, I would like to minimize the risks of a child I might have having a neural tube defect, obviously, but I might still want access to DTG. And here's the hard rub too. Giving women access to DTG, but only when they have agreed to long-term hormonal contraception, is not robust choice. It's choice. It's not robust choice. Because the same things apply. Highly contextual for women in their own life situations, how much access they have, how much they're planning to get pregnant. Why would I have to be on long-term hormonal contraception when I've already had my 3 children and I'm single, I'm not even dating, okay, and I don't want to be on long-term, or I'm trans, right? So a one-size-fits-all that I must be on long-term in order to get access to a drug that may be life-saving for me and make it possible for me to live my life because I might get pregnant, a little worrisome. Lessons going forward. Oh, that was the second manifesto point, sorry. Okay, women deserve an evidence base for medication use across the lifespan, including pregnancy and periconception. So this is a great poster child lesson that research like this is needed, even knowing that sometimes it gives us unexpected and deeply distressing findings, but it's more important to find out than not to look. Women of reproductive potential should not be seen as merely reproductive vessels. And policies must be made in ongoing consultation of communities of women living with HIV. Thank you.
Thank you very much to our panelists for some very fantastic presentations. We have 10 minutes left for the session, and I'd like to invite 1 or 2 questions, very short and brief comments. There's a lot that has been said. We will take only 2.
Let's see where it goes. We'll start and go around for as long as we have time. Ruben?
Right. Thanks, Ruben Granch. I'm a consultant. Thank you. It's a great panel. I really liked the last talk. It was fantastic. And the modeling was very interesting. And what I began to think about was that actually it's not about the woman and her child, but it's about the woman as being in the center of her household. So she has many children, right? And she has some of them that aren't hers, they're coming from outside. And then she has a partner, maybe, or maybe not, that's in the household as well. And then there's other partners. So the decision that she is making, we're asking her to make, actually implicates all of those people. So when you're making policy or you're doing a model or these sorts of things, it makes it muddy and very, very difficult, but you have to consider all those things in your outcomes. And I would suggest that when you do, then the decisions become a little bit easier on some level for the woman.
Trip Gulick from New York. Thank you very much for this panel. Rebecca and Lynn, could you comment? One of the most striking things about the data we heard is that the 4 neural tube defects are actually 4 different neural tube defects. Does this make sense from a mechanistic point of view? Are other drugs known to cause 4 different neural tube defects?
Yep. Hello. Valproic acid, which is a neural tube teratogen, doesn't just cause one type of neural tube defect. So remember, you've got the 2 areas closing. So you could have something that can hit one and the other. And that's why you can see, for example, I think it's called craniorhescesis, which is where it's open from the head all the way down. So I think it's unusual, but I don't think that it means that it isn't real. Does that answer your...
Thank you. I think Dr. Little told us that numbers will not always give us the answer, but a quick question. Data came out from the US, I think it's from the US in April, indicating that the blood placenta penetration of dolutegravir is much, much high, and the clearance from the infant is much, much lower. The concentration is 1.25 times the one in the mother plasma. So 2 out of 29 kids were found to have ultrasonographic abnormalities of the kidneys. In another study which came out from the US itself, 2 birth defects of 66 women, babies delivered from 66 women, and 32% premature delivery. So my question is, in the mathematical modeling, have you factored other morbidity and mortality that might come as a result of exposure to dolutegravir? That's number 1. Number 2, in a public health approach, we look at population level viral load suppression, which efavirenz is doing pretty well at the moment. It's not a real emergency that either dolutegravir is a cure to HIV or efavirenz suppression is critically low that HIV prevention and control is out of hand. Why the rush? How do you put it on the ethical integrity of the data we bring forward and the recommendation we made, so that after 37 years since HIV was first known, we're putting forward a conditional recommendation with very low level of certainty. This would be understandable if it was 1995. Thank you.
Great. I'll go ahead and respond especially to the first question there about whether our model looked at other morbidities important for both kind of a pregnant woman and also her infant. We did not have the opportunity in this analysis to look at factors like miscarriages, stillbirths, or preterm delivery. And those are really important factors to consider, not only for dolutegravir, but also for efavirenz and other ARVs. And I know that the SAPAMO team is working hard to collect a lot of that data as well. This was the first of, I think, what will be several analyses in our group looking at this sort of issue and these trade-offs, and we certainly hope to incorporate those in the future.
I think the second part of the question was for WHO. How did the guideline development group come out with a conditional recommendation for dolutegravir as an alternative, as a preferred first line? And the quality, the level of the certainty of the evidence for women of childbearing potential was based upon the evidence of the 4 cases of neural tube defect, and because these are case reports, they become very low quality evidence. But I think the thing to keep in mind is the conversation was also about the benefits of the drug in terms of viral suppression, in terms of CD4 recovery, in terms of side effect and discontinuation. And the guideline development group felt that those benefits outweighed the potential risk.
Number 3.
Thank you. Karen Beckerman, Bronx, New York City. Great panel. Thanks to everyone for this wonderful session. Just a couple of questions. I believe
we're going to ask you to do one question to everybody, please. Okay? So.
Okay.
All right, because we have a bunch of people and we have to be out of here at 6.
Can I go ahead?
Yeah.
Thank you. ARVs are the best studied drugs in history, and I believe that when there's a maternal death, that impacts the survival of the infants of a woman. And in your modeling, I didn't see that taken into account anywhere, and I think it's a very important thing that we need to add and look at. Thank you very much.
Thank you. Can we take 2 from number 2?
Hi, I'm Heather Berner from Medscape Medical News. I have a real basic question. What are doctors supposed to say to their patients right now?
Okay, my question. Okay.
Hello? Yeah, we can answer it.
Yeah.
Yeah, I mean, I think that what we know is the data for safety is what I presented, that there's 4 cases among 426, that's the initial data, and that's somewhere between 9 and 10 times higher than we expected, but that it's very preliminary, we don't know for sure. And then we can say what we know about dolutegravir in terms of viral suppression and side effects versus whatever other ART regimens might be available to that patient, which will really depend. And I think what it really brings it back to is the doctor's role is to understand what that woman cares about and how she values all of these and weighs these different things, because I think people will see this all very differently. So beyond just data, I think that is the crux, and figuring out how to do that in our lower resource settings where we have not been doing that in ART rollouts is a huge challenge and very important.
So was it yesterday or today? I don't remember. I brought up the example of Valproic acid, which is an anticonvulsant and is definitively associated with neural tube defects. But in women who have severe epilepsy and require that drug, they need to know the risks, but also the benefits. And in that case, the benefit of that particular drug likely outweighs the risk to the infant. Remember, we're talking about 1 per 100 here. So I think that's what you tell your patient, and the patient gets to think about what they would like to do, what's important to them.
There's also the question of alternative choices,
yes.
And choices are different depending on where you live, and information is transmitted by different providers and in different ways, and I think we're all just trying to figure out right now how best to do that. So let's do 1, 2. Oh,
okay, maybe I don't know what the doctor would say, but probably from the perspective of the women, what we would like the doctor to say to us is, what is dolutegravir all about? What information is there around it? What are the benefits? What are the risks? And then leave the choice to us. And probably that choice, not just probably, that choice will be informed by the information you will have given us. And it's important that you don't pity us against our children, our unborn children, because like we've said before, we find them our motivation to live. So don't start making us hate to have our children because we want to access a drug. Thank you.
Okay. Hi. I just wanted a quick question. What would your recommendation be for involving the pediatric HIV community in counseling women about these decisions? As oftentimes, like you mentioned, it's not the child who ends up making these decisions. And how can we be integrated into this moving forward?
So just a comment that when the Department of Health and Human Services guidelines were made, recommendations were made. That was done by the adult group, the pediatric group, and the perinatal group together, working together to come out with language that everyone agreed with. So I think the pediatric HIV community is already involved.
And from the WHO perspective, our guideline development committee is a merging as well of an adult and a pediatric and adolescent group. So it's representative of all the domains.
Sorry, to clarify, I meant in counseling of the woman, like more in practical application, because we don't tend to see them when this is happening. So.
I think what you do is you're bringing up a very good point about what is going to be the counseling on the provider side, and how does one integrate some of the provider counseling on initiation of ART that may have been done typically by those who are trained for adult treatment and care, and how do we bring in the perspective of those trained for pediatric care. And going forward, we really have to develop some operational tools and programmatic tools to better understand how we're going to do this on a public health perspective, on a global perspective. And I think all ideas are we're willing to hear those ideas and bring them into those programmatic tools.
Okay, we'll take the last two comments, number 5 and then number 2, and then unfortunately we have to close the session. Number 5.
Okay. My question goes to Botswana. My question goes to Botswana regarding the 426 women. Out of them, they are saying that there are 4. But could there have been a chance that there were more than 4 women who got pregnant during when they were taking DTG, and only the 4 that got the neurotubal defects, the concentration went on those and leaving out the ones that survived?
Thank you.
Just to clarify, you mean could there have been women on DTG at conception who had an early pregnancy that was lost? Or are you talking about...
okay, for example, like we are 8 women who got pregnant when we are on DTG. And probably 3 of us got the tubal defects and the rest didn't. And your concentration was only on those 3 that got the tubal defects, and then you left out those ones who were successful.
Sorry if it wasn't clear, but I was trying to point out actually the overall prevalence is quite low. So as 4 of 426, it's 422 who did not have a neural tube defect. That's still higher than the other groups, but again, even if this is a true signal, the overall risk is still low.
Thank you. The last comment, number 2.
Thank you. My name is Bernard from Tanzania. I have a comment on the question. Settings in Africa differ, and as we have seen statistics that has been presented here, even in Africa, almost more than 50% of pregnancies are unexpected pregnancies. So putting different conditions as to who should be on DTG and who should not be on DTG becomes a problem, because everybody knows the advantages of DTG, and they know exactly if they are on DTG, they will be very suppressed and they will not be able to transmit the virus to the children. So telling them that you be on contraception and you are on good drug, yet they can get pregnancies. So the chances of getting pregnancy while on DTG is very high. So I had a question. Out of the 4 cases that had neurotube defects, were there any folate levels that were analyzed to find out whether they had low folate supplements? And the last is, I would urge WHO and other stakeholders to act with urgency in determining the genetic perspective of the 4 kids. Thank you.
Just before Rebecca answers, I think you've laid out the problem, which is that 50% of women have unexpected pregnancies. I think the issue here is not necessarily the Dolutegravir. The issue is that these women should be able to access contraception if they want it, and that countries need to begin to fix the problem that you've outlined. Rebecca, go ahead.
Sure, and in terms of folate, people have been, since this came out, wondering if that could have anything to do with what happened. Could dolutegravir have some kind of effect on folate levels? Because if it was just low folate in the Botswana population, you'd expect to see the same results in each exposure group. So I don't think it's related to that, but people are now looking forward. Our study didn't collect any information on folate levels in the women.
I think we also all recognize that there have been many people and many organizations who have worked hard over the last decades to improve sexual and reproductive health and contraceptive options for women, particularly in low-resource settings, and that this is not an easy task. This is an opportunity now to potentially further that agenda and accelerate opportunities, but I don't think anybody up here thinks that this is going to happen overnight, and we will all be struggling with these data and these findings until we know one way or another if this is a signal. So your points are as well taken. On that note, I'd like to thank our speakers for their words of wisdom, and thank you all for attending.